So I want you to take a moment and just, picture something for me.
Okay, go ahead.
Close your eyes if you can. I mean, unless you're driving, of course.
Yeah.
But imagine you are getting a bit older. Or, well, maybe you've recently developed some sort of condition.
Right, like a severe mobility issue or maybe a cognitive challenge, right?
Exactly. Something that requires you to have daily assistance. And for decades, you have been the absolute master of your own domain.
Well, yeah. You decide when you wake up, when you eat, who comes into your house.
Yeah. Or when you just want to pull the curtains and be left completely alone.
Yeah.
But now, because of this, that entire reality has shifted.
It's a massive shift because you need help with your medications or just, some of your basic daily needs. Your routine is no longer your own.
It's really not. You're now waiting. You're just waiting for a stranger.
A well-meaning stranger, sure.
Yeah, a highly trained professional, absolutely. But a stranger nonetheless. And you're waiting for them to knock on your front door.
You're waiting for them to let themselves in, hand you your medication, check your vitals, and then finally leave so you can just get on with your day.
Right. You are living your life entirely on somebody else's logistical schedule. And it feels a bit like you are a guest in your own home, doesn't it?
It really does. It's this profound loss of agency. And honestly, it's a scenario that millions of people face every single day globally.
But what if you could evict that schedule?
Yeah.
I mean, what if the key to getting your autonomy back wasn't a better nurse or a more efficient transit route for the care worker, but just a piece of plastic sitting on your kitchen counter?
Which is wild to think about.
It is. And that is the quiet revolution we are unpacking today on this deep dive.
Because we so often talk about adult social care purely in terms of logistics, don't we?
Oh, completely.
We talk about it like it's a supply chain problem, like getting the right pill to the right person at the right time or maximizing the number of visits a carer can make in a 12-hour shift.
Right. It's all about efficiency.
Exactly. But we rarely pause to think about the psychological toll of that process on the actual person sitting in the living room.
Yeah, the sheer vulnerability of having to rely on an external, state-funded or private bureaucratic system just to maintain your basic baseline of existence. It's staggering.
It really is.
Okay, let's unpack this, because today we're going to look at how that entire paradigm is basically being dismantled and rebuilt.
And we have a truly incredible source guiding our analysis today, don't we?
We do. We are pulling from a fascinating broadcast from Champions Network TV. It's hosted by Major, and it's titled The Digital Care Revolution: How Technology is Transforming Health and Social Care in the UK.
But as we're going to see, the implications go way, way beyond just the UK.
Oh, for sure.
Yeah.
And this broadcast features two really vital voices from the front lines of this shift. First, we have Sam Islam.
Right?
She is a specialist occupational therapist, and she has 20 years of experience across acute hospitals, community services, rehabilitation settings, you name it.
Yeah, she is the person who actually walks into these homes. She looks at the environment, assesses the residents' physical and cognitive needs, and then figures out how to practically keep them safe.
Which is huge.
It is. Her perspective is really the anchor here because she represents the clinical, human-to-human reality of care.
Yeah, she's not some tech developer sitting in a Silicon Valley incubator brainstorming apps.
Exactly. She is a healthcare professional who has spent 2 decades dealing with the messy, complex, totally unpredictable reality of human bodies aging in human homes.
Right. And our second key voice brings a totally different but deeply complementary perspective. We have Vicky Wang.
Yes.
She is a service designer, and her background is so interesting because it spans the United Kingdom, China, and Singapore.
A really diverse global perspective.
Absolutely. She has worked extensively in design consultancy, health technology, and logistics. So her job isn't to, prescribe the medication or assess the trip hazards in a hallway.
Right. Her job is to design the overarching massive systems that allow that care to happen efficiently and humanely at a whole population scale.
Yeah, and when you merge those two disciplines, the occupational therapist who understands the intimate daily needs of a single resident, and the service designer who understands how to build international digital infrastructure, you really start to see the full picture here.
You do, because this isn't just about handing out iPads to the elderly.
Right.
We are looking at a fundamental rewiring of the entire philosophy of care. We're moving from physical intervention to digital empowerment.
So I want to start by looking at the reality on the ground in the UK, at least as Sam Islam explains it in the broadcast.
Okay, yeah.
Because to understand why this digital shift is such a revolution, we kind of have to look closely at the old regime first.
Makes sense.
Sam details what she calls the traditional UK care model,
Mm-hmm.
and she actually refers to these interventions as packages of care.
Yeah, and honestly, the terminology itself is super revealing.
It is, isn't it?
A package of care sounds, I don't know, industrial. It sounds like freight.
Yeah, like you're shipping a box.
Exactly. It kind of strips the humanity out of the interaction and turns it into a deliverable commodity.
It really does. But practically what she means by that is that residents receive a designated allocation of physical care, usually funded by the state or the local council.
Right, so carers physically travel to the home.
Yeah, often battling traffic and impossible schedules just to get there. They come inside, and they assist with highly personal tasks.
We were talking about assisting with personal hygiene, physically managing and administering complex medication regimes, preparing hot meals.
Yeah, it is a highly physical, highly scheduled intervention that literally requires a human body to be present in the room with the resident.
And, we absolutely must acknowledge that this traditional model was built from a place of deep compassion and necessity.
Oh, 100%.
For a long time before we had ubiquitous broadband and smart devices everywhere, this was the absolute best society could do to keep vulnerable people safe. But if we analyze the power dynamic of this model, it is inherently a model of reliance.
Totally. The resident is entirely dependent on the care provider.
Yeah. If the carer's car breaks down, the resident might not eat lunch. If the agency is short-staffed, the resident might not get out of bed until noon.
Which is terrifying, really.
It is. It completely removes the resident from the driver's seat of their own daily routine.
Which perfectly brings us to Sam's ultimate goal with this new digital revolution. I actually want to quote her exactly here because it really sets the stakes for our entire discussion.
Go for it.
She says the goal is, quote, giving that ownership and that control back to the residents of the UK, end quote. She wants them to actively engage in how they deliver their own care, to have a choice and to feel empowered.
And ownership and control are pretty radical concepts in this context.
Right.
Yeah, because in the vocabulary of adult social care or age-related cognitive decline, the prevailing words are usually management, safeguarding, and risk mitigation.
Yeah, not ownership.
Exactly. So by centering ownership and control, Sam is actively dismantling that traditional paternalistic model of healthcare.
The one where the qualified professional knows what's best and the resident just passively receives the service.
Precisely.
But let me play devil's advocate for a second here, though.
Okay.
Giving ownership and control back sounds lovely in a press release, right?
Sure.
But if you have an 85-year-old resident who has spent their entire life turning physical knobs on a radio, reading paper calendars, talking to human beings face to face.
I see where you're going.
Yeah, suddenly walking into their home and saying, good news, we're going to manage your critical heart medication through this glowing digital screen. That seems like a recipe for disaster.
Yeah, it really does.
Isn't that going to cause massive anxiety for them?
It is a massive cognitive and emotional leap, for sure. And Sam readily acknowledges this.
Oh, she does?
Yeah, she explicitly notes that for a significant portion of the older community, digital technology is a very new thing. She actually uses the words very daunting and very scary.
Well, I would be scared too, honestly.
Exactly. You are introducing a foreign object into their safe space and asking them to trust it with their health.
Right.
To overcome that friction, you cannot introduce technology that feels alien or overly clinical. You can't drop a complex, intimidating, sterile medical robot into someone's cozy living room and just expect them to embrace it.
Right. You need a bridge. You need something that feels domestic.
And that bridge is exactly what blew my mind in this source material.
Yes. Mija, the host of the broadcast, asks Sam what the single biggest game changer is in her current toolkit.
And I was fully expecting her to name some highly specialized $50,000 piece of proprietary hospital equipment that requires a PhD to operate.
Same. I was ready for some crazy sci-fi tech.
Right, but she doesn't. Her absolute go-to recommendation, the most popular device in her arsenal, is the Alexa Show.
The Alexa Show. It's completely consumer-grade tech. You can buy it at any electronics store right now.
A commercially available, off-the-shelf smart screen produced by Amazon.
Yeah, the exact same device that teenagers use to watch music videos while doing homework and families use to check the weather forecast or, set spaghetti timers.
Exactly. But the way Sam's team of occupational therapists is applying this basic consumer technology to solve complex health and social care needs is just brilliant.
It really is. Let's break down exactly how they deploy it, specifically regarding medication, because I found that fascinating.
Yeah, let's do it.
Sam gives the example of residents who struggle to remember to take their pills.
Yeah.
Historically, a carer would drive to the house 3 times a day, physically hand them the pill, and watch them swallow it.
Right.
Now, they set up automated visual and audio reminders on the Alexa show.
So the clinical outcome is the exact same. The resident takes the medication, but the psychological outcome is entirely different.
Completely. And Sam frames the dignity of this specific application so perfectly. She points out that they no longer have to have, and this is a direct quote, random people coming in to physically give them that medication.
Yeah, she notes that with the device, the residents are back in control of taking their own medication.
Which is a monumental psychological shift from being a patient to being a person again.
It really is.
I was trying to articulate this shift in my head, and I think it basically comes down to the difference between being chauffeured everywhere by a stranger versus having the keys to your own car.
Oh, that's an interesting way to put it.
Yeah, think about it. When you're being chauffeured, even if the car is, a high-end luxury vehicle,
Yeah.
and the driver's incredibly polite, professional, and safe, you are fundamentally not in control.
Right, you can only go where they take you precisely when they are available to take you.
Exactly. You have to make polite conversation when maybe you just want to sit in absolute silence. You are basically a passenger in your own life.
Yeah.
But when you have the keys to your own car, even if it's an old, beat-up sedan, you have autonomy. You decide the route. You decide the timing. You decide the music.
That is an incredibly apt analogy for this entire paradigm shift. What Sam Islam is doing by implementing the Alexa show is essentially handing the keys back to the resident.
Yeah.
When a state-appointed carer unlocks the front door to administer medication, the resident is the passenger. They are just the recipient of a service.
Right.
When the Alexa show chimes with a friendly reminder and the resident physically stands up, walks over to their pillbox, and takes the medication themselves, they are the driver.
They're actively managing their own health.
Exactly. The technology is merely an assistive tool, like a navigator, not a replacement for their fundamental agency.
But wait, what if they don't take it?
What do you mean?
Well, what if the Alexa chimes and the resident just ignores it, or they're asleep, or maybe they fell? If you remove the human carer, haven't you just removed the safety net?
Right. Well, that's the critical role of the occupational therapist in this system.
Okay.
They don't just hand down an Alexa and walk away. The system is meticulously designed with fail-safes.
Like what?
The devices can be linked to family members or a remote monitoring center. If the resident doesn't acknowledge the prompt, or if the device detects a lack of expected movement in the house, it escalates.
Oh, I see.
Yeah, it might trigger a phone call to a daughter, or eventually it could dispatch a physical carer.
Okay, so the technology acts as the first line of defense, basically filtering out the routine needs so that physical human intervention is reserved for actual emergencies.
Exactly. Or for complex care that a machine simply cannot provide.
That makes a lot of sense. And it goes beyond just medication prompts, too.
Right.
Sam also talks about using the Alexa show for people with partial sensory difficulties. Imagine someone whose vision is failing or who struggles with hearing.
That makes it really difficult to safely navigate their environment or even answer a traditional telephone.
Right, which naturally makes their families incredibly anxious. The adult children are constantly worrying, is mom okay? Did dad fall in the kitchen?
Oh, absolutely.
So they use the drop-in video call feature. The family can visually check in, feel reassured that their parent is sitting safely in their armchair, and just touch base without having to physically drive across town during a workday or demand that a state carer go do a welfare check.
And what is so compelling about this application is how the technology addresses the holistic ecosystem of care.
Yeah, it's not just the patient.
Right. It's not just treating the physical deficit of the resident, it's actively treating the family's psychological anxiety.
Wow, yeah.
It reinforces and strengthens the natural social support structures that already exist, the bond between parent and child, rather than replacing those organic structures with state-funded professionals.
That's such a good point. This simple piece of commercial tech reduces the financial and logistical burden on the social care system while simultaneously improving the emotional well-being of the entire family unit.
Exactly. Independent living, in this context, doesn't mean you never need help. It means you have the digital tools to manage and curate that help on your own terms.
And the results are really tangible. Sam notes that because of this technology, they've actually had people realize they can manage entirely on their own, completely removing the need for traditional physical care packages.
Which is incredible.
It is. But as fascinating as the UK rollout is, they aren't operating in a vacuum here.
No, definitely not.
I want to shift our focus to the global perspective of this source material, because this is where Vicky Wang's expertise really shines.
Yes.
How does this UK approach compare to what the rest of the world is doing?
Well, Vicky brings a macroeconomic and cultural lens to this issue that is absolutely vital. Remember, as a service designer who has operated in the UK, China, and Singapore, she understands that you can't just copy-paste a technological solution from one culture to another.
Right. You can't just ship an Alexa to every country and expect the same result.
Exactly. It's
Yeah.
not just about the technical specifications of a device. It's about how different societies innovate, how they tolerate risk, and how they adopt these complex systems.
So let's start with her insights on China. Meija asks her how her international experiences shape her perspective, and she immediately points to the pace of development in China's internet companies.
Yeah, she describes it as incredible fast.
She does. She talks about a methodology where they shape a rough concept,
Yeah.
put it out there, get real user feedback within days, and then rapidly iterate and improve the product. It's a breakneck speed of deployment.
She is essentially describing the classic agile methodology, but applied at a massive societal scale.
Right.
In China's tech sector, the cultural tolerance for rapid deployment and on-the-fly iteration is exceptionally high. You don't sit in a boardroom for 3 years trying to anticipate every single edge case and wait for a system to be flawless before putting it in the hands of users.
You just go for it.
You launch the minimum viable product, you watch closely to see where it breaks, you listen to the user complaints, and you patch it in real time.
Yeah, and this learn-by-doing approach is highly effective for rapidly advancing the capability of technology. But it stands in stark contrast to the more cautious, heavily regulated, risk-averse environments we typically see in Western publicly funded healthcare systems, like the NHS.
Oh, totally.
But wait, isn't that dangerous when we're talking about health?
How so?
Well, if a food delivery app crashes in China because they launched it too fast, someone gets their noodles late, right?
Right.
If a medication management app crashes, someone could literally end up in the hospital. I just struggle to see how you can responsibly apply that move fast and break things philosophy to vulnerable elderly populations.
And you're highlighting the exact friction point of global health tech right there.
Yeah.
Pure agile methodology is dangerous in healthcare if there are no guardrails. However, the lesson to extract from China isn't necessarily to abandon safety testing, but to embrace the speed of user feedback.
Oh, I see.
The UK system historically struggles because it takes years to procure a technology, and by the time it reaches the resident, it's completely obsolete.
That makes sense.
The Chinese model demonstrates the power of getting real-world data quickly. The challenge is finding the middle ground, launching safe, small-scale pilot programs quickly, rather than waiting for national perfection.
Which perfectly transitions to Vicky's experience in Singapore, because she provides a crucial counterweight to that obsession with speed.
She really does.
She shifts the conversation to the concept of technology for good. She mentions attending a major conference in Singapore involving startups, students, government officials, massive tech companies, everyone.
Right.
And the core anxiety of that conference wasn't about how to build things faster. It was about the danger of digitizing services too comprehensively.
Yeah.
The discussion centered on what happens to the people who aren't tech-savvy when every essential service moves to an app. She explicitly warns that if you don't design with extreme intention, there's a real chance certain groups will get, quote, left out.
And that is the dark side of rapid innovation.
Yeah.
If you digitize at a breakneck pace, you inevitably create a digital divide, leaving the most vulnerable populations behind.
Definitely.
Singapore is a highly developed, densely populated city-state that relies heavily on systemic efficiency to function. But Vicky highlights their acute, conscious awareness of inclusivity.
Because they have an aging demographic too, right?
Exactly. The government recognizes that it doesn't matter how fast or brilliant a health app is if an 80-year-old citizen doesn't know how to navigate the user interface or if they don't even have a modern smartphone to run it.
Right.
Her time in Singapore clearly instilled in her a comprehensive view of service design. Technology never exists in isolation. It is inextricably woven into the social fabric, and if the fabric tears, the technology fails.
Wow. And this philosophy becomes even more critical when Mia brings up a question from a hypothetical viewer watching from a developing nation.
Oh, that was a great moment.
It was. The viewer's implied concern is essentially, look, this is all great for a wealthy nation like the UK or a hyper-connected city like Singapore, but we don't have ubiquitous high-speed broadband in every home. We have inconsistent power grids. How on earth can digital care help us?
It is the ultimate reality check for this entire conversation.
Completely.
If we restrict our definition of digital care exclusively to expensive smart screens, passive AI sensors, and high-bandwidth video calls, we are effectively excluding a massive portion of the global population from this revolution.
Vicky's response to this is brilliant because she immediately strips away the elitism of tech.
Yeah.
She tells the viewer that technology for health and care doesn't mean a very, very high tech. She emphasizes that its value depends entirely on how you use it and how you embed it into whatever existing system you have.
Yes.
And then she delivers what I consider the thesis statement of her entire profession.
Let's hear it.
She says, if the systems still don't know how to use it, they will just leave the technology somewhere. And it's such a big waste.
Yeah. That quote is the absolute bedrock of effective service design.
It really is.
Innovation is totally useless without cultural embedding and infrastructural alignment.
Yeah.
You can use international aid money to helicopter a $1 million state-of-the-art diagnostic machine into a rural clinic in a developing nation. But if the local staff hasn't been extensively trained in its software,
Or if they don't trust it.
right, if the patients are culturally suspicious of the machine, or if there simply isn't a reliable power grid to keep it turned on, that machine just becomes a very expensive, very tragic paperweight.
It gets shoved in a supply closet.
Exactly.
So I have to ask, what does this mean for our definition of the best technology?
Right.
Because Mitra brings up WhatsApp as an
That's
example.
a perfect example.
Right. WhatsApp is ubiquitous globally. It operates on incredibly basic, cheap smartphones, and it requires very little data bandwidth. And it strikes me that a simple, well-organized WhatsApp group, used to coordinate care, share health updates, and arrange transport among family members and neighbors in a developing nation, might actually be far more effective in its real-world impact than some multi-million-dollar proprietary health portal in a wealthy Western nation.
Oh, without a doubt.
Because nobody actually logs into the fancy portal because they forgot their two-factor authentication password, and the interface is a nightmare.
Your assessment is spot on. We have to decouple advanced technology from effective technology.
Yes.
The best technology is unequivocally the one with the highest rate of functional adoption.
Okay, that makes sense.
If a community in a developing nation already uses WhatsApp daily to gossip, to arrange community events, to share local news, then the behavioral friction required to use it for healthcare coordination is virtually zero.
Right, because you are piggybacking on existing ingrained behavioral habits.
Exactly. This is what Vicky means when she says it's a system levels thing, and that it always comes back to the people. You have to design your care model around the resources and habits you actually possess, not the pristine resources you wish you had.
Here's where it gets really interesting, though.
Okay.
Whether you're using a sophisticated AI sensor in London or a WhatsApp group in a developing nation, working with these digital tools requires one fundamental element: trust.
Yes.
If the people don't trust the tool, they won't use it, no matter how simple or accessible it is. So how do you actually ensure these tools are safe? And more importantly, how do you convince the public that their highly sensitive data isn't being exploited?
It's a huge hurdle.
Because, as Mitra points out in the broadcast, for every person excited about digital innovation, there is someone who is deeply concerned about privacy, data harvesting, and having their personal medical history floating out there on a server somewhere.
It is the central animating tension of the digital age, and it is amplified 100-fold in this context because we are dealing with deeply sensitive, intimate medical and behavioral data.
Right.
We aren't talking about an algorithm tracking your shoe shopping habits. We are talking about a system that tracks when you sleep, what heart medication you require, and when you are physically incapacitated in your own home.
The stakes are so much higher.
The stakes for privacy breaches are literally existential.
And Sam directly addresses this widespread anxiety. She explains that it's not just a free-for-all where local councils are buying cheap gadgets off the internet.
Thank goodness.
Right. Every single piece of technology chosen for the UK program goes through rigorous background work. They assemble design groups that feature actual community residents sitting alongside clinical professionals from various backgrounds.
That's a great approach.
It is. These groups review, touch, and test every device. And structurally, everything must strictly comply with GDPR, the General Data Protection Regulation, and stringent data protection protocols to ensure absolute anonymity and confidentiality.
The inclusion of actual community residents in those design and testing groups cannot be overstated, honestly.
Why is that so crucial?
Because it democratizes the vetting process. It ensures the technology isn't just technically safe, according to a corporate lawyer in London, but practically safe, culturally acceptable, and intuitively understandable, according to an 80-year-old grandmother who will actually have this device sitting on her nightstand.
Yeah, that makes a ton of sense. And while Sam is describing this rigorous multi-layered testing process, Mija, the host, does something really great.
What's that?
He synthesizes everything she's saying and spontaneously coins an acronym right there on the broadcast. He calls it the NAS framework, NAS.
Oh, I love that part.
And both Sam and Vicky react immediately. They love it so much they actually joke about stealing it and officially embedding it into their own assessment programs.
It's a brilliant, elegant distillation of the entire vetting philosophy. If we break down Mija's NAS framework, it provides a perfect lens for how we should evaluate literally any health technology.
Let's do it. Let's break it down. We'll start with the N. The N stands for need. Does the device actually meet a specific need?
This is the critical first hurdle. It prevents the phenomenon of tech for tech's sake.
Right, which happens all the time.
Exactly. If a resident has a specific problem with physical mobility, say, they struggle to stand up from a chair, putting a high-tech smartwatch on them that monitors their blood oxygen levels might be technologically impressive, but it doesn't meet the primary need.
Right, it doesn't solve the problem at hand.
The technology must be a direct, targeted response to a clinically or socially identified deficit. Otherwise, it's just clutter.
Right, it can't just be a shiny toy the council bought in bulk. Okay, then we move to the A. Accessible. This is accessible to the resident.
Accessibility in this context is deeply multifaceted.
How's
On one level, it means physical accessibility. Can a person with severe rheumatoid arthritis actually push the buttons? Can a person with macular degeneration read the font on the screen?
Okay, yeah.
But it equally means cognitive accessibility. Is the menu navigation intuitive, or does it require memorizing a 50-page manual?
Oh, that's huge.
If the resident cannot comfortably and confidently interact with it, it utterly fails the A-test, regardless of how perfectly it theoretically meets their medical need.
Absolutely. And finally, the S. Simple. Is it simple enough to use in daily life?
Simplicity is closely related to accessibility, but it speaks more to the ongoing operational friction.
Like maintenance.
Exactly. If a device requires constant software updates that the user has to authorize, frequent battery changes with tiny screwdrivers, or complex recalibration every single whack, it is not simple.
It's sure.
Simplicity ensures that the device can seamlessly fade into the daily rhythm of life without becoming an administrative chore in itself.
Need. Accessible. Simple. The NAS framework. It really seems like the holy trinity of digital care.
It does.
But beneath all of this logic, beneath the strict GDPR compliance, the rigorous code design groups, and the NAS framework, is the absolute bedrock emotional issue of trust.
And this brings us to a fundamental truth about data in healthcare.
Okay.
In the broader digital economy, the cliche is that data is the new oil. It's a commodity to be extracted. But in digital healthcare, trust is the absolute currency.
Right.
If the resident does not inherently and genuinely believe that their data is safe, the entire NAS framework falls completely apart.
Why is that?
Because the resident retains the ultimate, undeniable veto power over the entire multi-million-pound system.
Which is?
They can simply reach behind the table and unplug the device from the wall.
Yes, I love that image.
It's the ultimate reality check.
You can have a device that costs a fortune in R&D, it perfectly meets a medical need, it's highly accessible, brilliantly simple, and a team of lawyers has certified it is 100% GDPR compliant. But if the resident feels an underlying dread that the government is monitoring how many times they go to the fridge, they're going to walk over, pull the plug out of the socket, throw the device in a drawer, and the whole system fails.
Precisely. And this is exactly why Sam and Vicky emphasize that the rigorous vetting isn't just a bureaucratic checkbox. They aren't just legally protecting the data. They are actively working to build and maintain the psychological trust required for the service to exist at all.
Because it's hard to trust big tech right now.
Exactly. They are fighting an uphill battle against the pervasive cultural narrative that all technology companies are fundamentally predatory and just want to steal and monetize personal information.
Right.
In social care, proving to the resident that you are safe is just as vital as the technical reality of being safe.
Okay, so let's imagine a scenario where everything works.
Okay.
A device passes the NANS test with flying colors.
Yeah.
It meets the need, it's accessible, it's simple, the data is locked down, and crucially, the resident trusts it completely.
Sounds perfect.
You would naturally think that rolling this out would be incredibly easy. You'd think every council in the country would be clamoring for it tomorrow.
You would think that, yes.
But that leads to the most surprising revelation in this entire analysis. If the tech is safe and simple, who is hitting the brakes? Why isn't this ubiquitous yet?
Because replacing a piece of hardware is relatively easy. Changing ingrained human behavior is incredibly difficult.
Yeah.
And attempting to change institutional human behavior within massive legacy bureaucracies like the UK's social care system, that is almost impossibly complex.
Mija asked Sam about the greatest challenge she faces in terms of widespread uptake, and I was certain she was going to say it was the elderly residents resisting smartphones.
Everyone assumes that.
But she doesn't. The biggest hurdle, the absolute bottleneck, is the professionals. It's the social workers, the care assessment teams, the very people whose entire professional mandate is to assess needs and recommend solutions.
Yeah.
Why on earth are the professionals resisting the tools that make their jobs easier?
It sounds counterintuitive, but if you look at it sociologically, it makes perfect sense. These professionals operate within a deeply entrenched paradigm.
What do you mean?
Well, for decades, the default institutionalized answer to a social care deficit was a human intervention. If an assessment showed a resident couldn't cook safely, the solution was to authorize a human to go cook for them.
Right.
If they couldn't remember their pills, the solution was a human to dispense the pills. You are now asking these highly trained professionals to fundamentally alter their diagnostic toolkit and trust a plastic screen to do the job of a nurse.
But let me push back on just calling it a paradigm shift for a second.
Sure.
Isn't it also about massive professional liability?
Oh, absolutely.
If a social worker assesses a vulnerable adult, and instead of prescribing a human carer, they prescribe an Alexa show to manage life-saving medication, and the Wi-Fi drops, the Alexa doesn't chime, and the resident ends up in a coma, who gets sued?
The social worker.
That's exactly. Who loses their professional license? The social worker does. So their hesitance isn't just stubbornness, it's self-preservation.
That is an excellent point, and it cuts to the core of the issue. The liability is immense. If a social worker doesn't confidently and technically understand exactly how the Alexa show manages medication reminders, what the fail-safes are, and how the escalation protocols work when the Wi-Fi drops, they will never, ever recommend it to a vulnerable client.
Right.
Their professional license, their livelihood, and their conscience are on the line. In the face of uncertainty, they will always default to what they know categorically works and what the legal system understands, which is a human carer.
Sam approaches this bottleneck with a lot of empathy, though, which is nice.
She does.
She says it's about a long-term culture change. It's about helping the professionals feel, in her words, confident and competent in suggesting technology to a resident.
Yeah.
Her ultimate goal isn't to replace the social worker's judgment, but to make technology just another tool in their toolkit alongside their traditional physical assessments.
And Vicky, approaching it from the service design angle, echoes this sentiment entirely.
She does.
Yeah, she states clearly that the biggest challenge in her field is never, ever about the technology bit. The technology exists and it works.
The tech is the easy part.
Exactly. The monumental challenge is introducing completely new ways of working to massive service teams. It requires immense ongoing training, psychological reassurance, and a lot of patience to reshape the working culture and the legal frameworks within these giant local council organizations and the NHS.
So while the massive institutions and the professionals are slowly, cautiously adjusting to this new reality, what is happening with the residents themselves?
That's a fascinating part of this.
Sam describes the resident uptake as a mixed bag, which I found wonderfully honest.
Yeah, very pragmatic.
She readily acknowledges that there will always be a pocket of people who just flat out reject tech. They don't want it, they don't trust it, and she says, quote, "That's absolutely fine, we're not going to push it on people."
And that fundamental respect for the individual's choice is a vital ethical safeguard. You cannot mandate digital adoption in social care without crossing into authoritarianism.
Right.
But what is truly fascinating is the mechanism of adoption among the residents who are open to it.
Yes. It's word of mouth.
It is.
Sam talks about how residents hear from friends of friends that this new technology is actually helping them stay independent and stay in their own homes longer.
Yeah.
And because of that organic peer-to-peer network, the care teams are actually seeing residents calling the front door of the service to self-refer.
Which is huge.
They're picking up the phone and saying, "Listen, I was talking to my friend Doris, And she got this screen that reminds her to take her pills, and she feels so much better. Am I eligible for one?
The power dynamic shifts entirely when it's organic demand generation.
Yeah.
When a state professional suggests a device, it can easily feel like a clinical prescription, or worse, it can feel like a cost-cutting measure where the government is trying to take away their human carer to save money.
Oh, for sure.
But when your friend Doris tells you over a cup of tea that she feels significantly safer and more independent because of her new gadget, it ceases to be a state intervention and becomes a desirable lifestyle enhancement.
And to make it desirable, to make it something Doris wants to talk about, sometimes you have to strip away all the futuristic complexity.
Definitely.
Sam talks about one specific piece of technology that I absolutely fell in love with during this analysis.
Oh, I know which one you're talking about.
It's the complete opposite of a complex AI-driven smart home system. It's a device they simply call the Press Me button.
It is the absolute epitome of the Nest framework in action. It perfectly embodies need, accessible, and simple.
Let me describe this thing because it's just brilliant. It's literally just a discrete, physical little button. That's it.
Yep.
There is no glowing screen. There are no confusing menus to navigate, no passwords to remember.
Just a button.
If the resident is home alone and they're feeling anxious, or they've had a minor slip but aren't seriously injured, or they just need support, they press the physical button.
And here is the genius part of the design. Pressing it does not trigger a massive, terrifying siren at a centralized emergency call center.
Right, resulting in an ambulance showing up with flashing lights and breaking down the door.
Exactly. Instead, it sends a simple text message functioning over a cellular network like a WhatsApp, directly to a pre-chosen loved one.
The pre-programmed message could be, "I'm feeling sad," or my absolute favorite example Sam gave, "I need a cup of tea."
Such a human need.
I have to tell you, the idea of the Press Me button brought me so much genuine joy.
Why is that?
Because it's not tracking your vitals, it's not counting your steps, it's simply empowering you to ask your daughter or your next-door neighbor for a cup of tea, exactly when you want it, without having to fumble with dialing the smartphone or feeling like you are making a massive fuss.
If we look closely at the sociological power dynamic of the Press Me button, it is profoundly revolutionary. Yes. Consider the traditional care model. If you are a resident and you desire a cup of tea and a chat, you have to wait for your state-scheduled carer to arrive at precisely 2:00 p.m.
Right.
Your fundamental human desire for social interaction and a warm drink is entirely dictated by a local council's logistical schedule.
That's depressing when you put it like that.
With the button, you are initiating the interaction based purely on your internal desire and your own timeline.
Yeah.
Furthermore, and this is crucial, you get to choose who responds to you. Sam explicitly points out how vital it is that the resident gets to choose their responder.
Because there's a difference between your daughter and a carer.
Exactly. Reaching out to your daughter for a cup of tea is a natural, dignified, reciprocal human interaction. Relying on an assigned care worker for that same cup of tea is a clinical paid transaction.
Oh, yeah.
The Press Me button uses technology to restore agency, spontaneity, and natural social bonds.
But wait, how do the traditional care providers feel about all of this? The agencies whose entire business model is built on billing the local council for the physical hours their workers spend in these homes.
It's definitely a point of friction.
Sam admits it's an interesting journey with these agencies. Some embrace it fully. They run pilot projects where they use video calls just to prompt someone to take medication, replacing a physical 15-minute visit.
Right.
But others are highly hesitant, needing a lot of support to understand how a digital interaction can legally and ethically be considered care.
It is a classic example of industry disruption.
Yeah.
The traditional care providers are fundamentally geared, both operationally and financially, toward billing for physical hours spent in a domicile. When technology starts efficiently reducing those required hours, it inevitably causes financial and structural friction.
Makes sense.
However, Minja makes a fantastic point in the source material about the immense benefit this technology offers to these exact providers. He notes that this technology can drastically reduce severe safeguarding concerns.
Right. He gives the heartbreaking but really common example of a carer finding someone on the floor.
Exactly. Let's walk through that scenario without technology for a second.
Okay.
A carer might be scheduled to arrive at 4:00 p.m. They unlock the door and find that the resident fell at 10 a.m. and has been lying on the floor in distress for 6 hours.
That's horrifying.
It is a traumatizing safeguarding crisis for the resident, and it is a massive psychological blow to the carer who feels they failed, even though they were just following the schedule.
Yeah, they couldn't have known.
With simple technology, whether it's a press me button or a fall sensor, the incident is detected or reported immediately. The intervention is swift.
Right.
The resident suffers less, and the profound burden of walking into a catastrophic, preventable situation is removed from the daily care worker.
So while the technology disrupts the agency's traditional billing model, it fundamentally improves the safety net they're ultimately trying to provide. Which perfectly transitions us to the final frontier of our discussion today. We've talked extensively about the simple tech of today, the off-the-shelf Alexa shows, and the beautifully simple press me buttons.
Right.
But what about tomorrow? Mija asks Vicky, the service designer who thinks in terms of decades, to look into the future. And she gives an answer that is both incredibly scientifically exciting and, honestly, slightly terrifying.
Yes, she moves the conversation entirely away from active interaction and introduces the concept of passive monitoring.
She predicts that the future of care is a sophisticated combination of passive monitoring sensors and artificial intelligence.
Which is a huge leap.
It is, because currently, even with the simplest tech we've discussed, the user still has to do something. They have to physically press a button or verbally respond to an Alexa reminder or strap on a blood pressure cuff.
Right.
Vicky points out that for some highly vulnerable or cognitively impaired people, this required interaction actually causes significant anxiety. Did I press the button long enough? Is the machine working? Did I do it right?
Yeah, the cognitive load is still there.
Exactly. Her vision for the future is a system where the technology is completely invisible. It passively collects data from the environment movement sensors, heat signatures, acoustic monitoring, and uses AI algorithms to predict early health patterns and intervene before a crisis happens, all without the resident having to lift a single finger.
But this raises an important question, perhaps the most critical ethical question of this entire technological transition.
Note that.
When does helpful, benevolent monitoring cross the line and become invasive, dystopian surveillance?
Oh, wow.
Vicky herself immediately flags this as her primary concern. She says she is very, very conscious about data privacy.
I mean, she has to be.
Because if you think about the mechanics of this, if you have sensors passively monitoring a person's every single movement, tracking exactly how often they go to the bathroom in the middle of the night, analyzing the speed of their walking gait down the hallway, logging precisely when they open the fridge, you are essentially gathering a complete, granular, highly intimate data profile of their entire existence.
That is deeply unsettling when you lay it all out like that.
It is. She warns, quote, "You don't want to over-monitor that people or make them feel like I don't have any privacy."
I mean, it is the ultimate tightrope walk, isn't it?
It really is.
On one hand, you want to use AI to predict that a resident's gait has slowed by 15% over 3 days, signaling a potential urinary tract infection or an impending fall, and treat it before they end up in the emergency room.
Which is miraculous.
It is. But on the other hand, you don't want the resident to feel like they are living in a panopticon, constantly judged and scrutinized by an invisible algorithm hidden in their ceiling smoke detector.
Exactly.
It's like having a digital seismograph in your house. It doesn't care what you're saying or what TV show you're watching. It's purely looking for the behavioral tremors, a change in your walking gait, an extra trip to the bathroom that signal an earthquake is coming in your health.
The seismograph analogy is perfect because it highlights that the AI isn't watching you like a security camera. It's analyzing patterns of metadata. But even metadata feels invasive. And this brings us right back to the NAS framework and the absolute necessity of trust.
Yeah.
The more passive and intelligent the technology becomes, the higher the burden of trust required from the user. We are going to have to develop entirely new, robust, legal and ethical frameworks to govern predictive AI in the home. It cannot just be left up to tech companies' terms of service.
Oh, for sure. But before we get completely lost in the philosophical and sci-fi future of AI algorithms, Mija grounds the conversation with the ultimate, gritty, real-world question.
The funding.
Yes. Who pays for all of this? State budgets are incredibly tight everywhere, and the NHS is constantly under financial strain. If I am an elderly resident in the UK, is buying an array of smart screens and sensors going to completely bankrupt me?
Sam gives a very clear, definitive answer regarding the UK system here, and frankly, it is a massive relief for anyone worried about the financial burden.
Oh, good.
She states clearly that if the technology is deemed to meet a legitimate care need under the CARE Act, which covers social care, or the NHS Health Needs Act, it is completely free at the point of delivery for the resident.
That's amazing.
The individual is not expected to go to an electronics store and purchase the tech themselves.
And she emphasizes this point. The only potential financial charge a resident might face in this model is if physical social care, meaning a human being dispatched by the local authority, has to physically come out to assist them.
Okay.
For example, if they have a fall, trigger an alarm, and have no local family to help them up. And even in those instances, she notes it's typically a very low subsidized cost.
But the technology itself.
The hardware, the software licenses, the digital service monitoring that is completely covered by the state if it meets a verified clinical or social need.
This financial reality completely changes the incentive structure of care, doesn't it?
She points out that because all the technology is free, it's actually opening doors that were previously closed. Under the old system, traditional physical care providers almost always came with some element of cost or copay to the resident.
Right.
Now, if you have a family member willing to be the responder on the other end of a free Press Me button, the system empowers and facilitates that organic network at zero cost to the user. It financially incentivizes family engagement and community cohesion over just reliance on the state.
But we have to be realistic about the back end of this system, too.
What do you mean?
Administering a massive, free, digitally integrated hardware and software service across dozens of different, notoriously siloed bureaucracies like independent local councils and various NHS trusts is a monumental administrative task.
Oh, absolutely. It sounds like a nightmare.
It is. And Vicky, bless her, is brutally honest about the unglamorous, gritty reality of being a service designer trying to make this actually work on a random Tuesday morning.
Yeah, she admits that right now, the referral forms for professionals to order this technology are way too long and cumbersome.
Right.
She explains that they have to connect with what she politely calls old infrastructure. There are severe system limitations where professionals literally have to double key information, typing the exact same patient data into two different systems just because they don't talk to each other.
This is the frustrating reality of public sector innovation.
Yeah.
You can have a brilliant, perfectly realized vision for an AI-powered future of passive monitoring, but today you still have to figure out how to make a modern API, which is essentially a universal digital translator that allows two apps to seamlessly share data talk to a proprietary, closed-loop database that a local council bought in 2004.
I can only imagine the headache. But I absolutely love their overarching philosophy for dealing with this bureaucratic friction.
Yeah.
They actively work to avoid what they call paralysis by perfection. Mija points out during the broadcast that if you wait for something to be utterly perfect, completely seamless, and universally accepted before you launch it, you will literally never launch anything.
Vicky agrees completely.
Instead of waiting years for a flawless, unified IT system, they utilize small-scale test-and-learn sprints.
Right.
They launch imperfect services. They get the tech running in a few dozen homes.
Yeah.
They learn from the inevitable mistakes. They patch the problems, and they iterate step by step.
This approach echoes the rapid iteration she observed in the Chinese tech sector, but applied carefully within the clinical safety constraints of the UK system.
Exactly.
Paralysis by perfection is a chronic disease in public sector innovation. The political fear of a failed launch is often so high that projects spend 5 years in committees, undergo endless risk assessments, and are technologically obsolete by the time they finally launch. By embracing these test and learn sprints, they consciously accept minor administrative friction, like making a social worker fill out a clunky referral form in exchange for the massive benefit of getting life-changing technology into vulnerable people's homes today.
I relate to that concept so deeply. In any field, in any creative endeavor, or just in life, if you wait for the absolutely perfect, frictionless moment to act, you miss the chance to do good today.
Precisely.
A clunky referral form is a frustrating but ultimately very small price to pay if the end result is an 85-year-old woman getting an Alexa show that allows her to safely manage her own medication and retain her independence this afternoon.
The perfection they are striving for is in the human outcome, the retained dignity, the extended independence, not in the flawless elegance of the administrative back-end process.
Well, we have covered an immense amount of ground today.
I really have.
We started by looking closely at how an off-the-shelf Alexa show is revolutionizing the UK care model, replacing the physical administration of medications and fundamentally returning ownership and control to residents.
And then we zoomed way out to look at the global pace of innovation.
Right, contrasting China's rapid, agile prototyping with Singapore's vital focus on inclusivity.
And the crucial reminder that sometimes the best, most effective technology for a developing nation is just a brilliantly organized WhatsApp group.
We dissected Minja's brilliant NAS framework, ensuring technology meets a need, is accessible, and is simple.
And we explored deeply why rigorous co-design vetting is the absolute only way to build the psychological trust necessary for any digital adoption to survive.
We looked at the real-world friction, acknowledging that the biggest hurdle isn't actually the tech, but the liability and culture of care professionals.
We marveled at the beautiful, empowering simplicity of the Press Me button, a device that restores the dignity of simply asking a loved one for a cup of tea.
And finally, we looked ahead to the promises and privacy perils of AI seismographs, the realities of state budgets, and the vital importance of pushing past the paralysis of perfection to deliver care today.
It
Really is.
But as you absorb all of this information, I want to leave you with a final thought to mull over, building on Vicky's vision of the future.
Okay.
As we inevitably move toward a future of seamless, invisible AI monitoring systems that passively watch our routines, analyze our metadata, and predict our falls before they happen, then we have to ask ourselves a difficult question.
What's that?
How do we ensure that in our relentless quest to perfectly protect the vulnerable, we don't accidentally design away their right to privacy, their fundamental right to make a mistake, and the beautiful, unpredictable spontaneity of being human?
Man, that's heavy. But it's an incredibly delicate balance between absolute safety and true autonomy. And it's a conversation that is really only just beginning.
Thank you so much for joining us on this deep dive. Keep questioning the systems around you, keep looking for those simple solutions, and remember, the next time you hear a knock on the door, think about the quiet revolution happening in homes all around the world, where technology isn't just a gadget, but the key to getting your life back. Take care, and we'll catch you on the next deep dive.